triage patient. Patient's name is Daniel Williams. She's 36-year-old G7P6, coming in for high blood pressure. She is 38 weeks and 6. Current blood pressure is 176/112 at noon. I validated the blood pressure in 10 minutes, and it was 170/110. EFM reveals a Category 1 tracing, and her past medical record includes 5 prior vaginal deliveries, chronic hypertension, and history of severe preeclampsia in 3 of her previous pregnancies, as well as a postpartum hemorrhage in the last pregnancy, which puts her at a high risk for postpartum hemorrhage, as you know. Her cervical exam is 150 at -3 station. Okay?
So let's go ahead and start an IV, treat the blood pressure with 20 of labetalol to get treated under 160/110. I'll put those orders in and I'll put you in there.
All right, meet you in the room.
Ms. Williams and Dr. Jackson, your blood pressure is too high. We're a little worried you might have something called preeclampsia, so we're going to admit you to labor delivery for induction of labor. Dr. Galati knows about that and agrees with it. I'm already started medicine called oxytocin to start your contractions. I'm going to start you on a medicine called magnesium sulfate to treat your preeclampsia. Okay. Jennifer, please start her at a 4-gram bolus, 2 grams per hour maintenance for seizure prophylaxis and draw laps.
Hi, Dr. Galati. This is Jennifer taking care of your patient in 1235. Yes, she's actually completely dilated and she's ready to deliver, so please come over for delivery. All right, see you then. Thank you.
Okay.
Okay. All right. Okay, Miss Williams, go ahead and push. You got it. Push. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Great job.
Awesome.
Okay, there's the head.
Okay.
And take a deep breath and push again.
Push.
And there's the anterior shoulder.
Okay.
Let's go ahead and start our Pitocin.
Perfect.
And all right, here comes your little one. Congratulations.
Yay!
It's a boy.
It's a boy. There you go. We'll put your skin to skin here. Great job. Congratulations. Awesome.
All
He's
right,
so cute.
I'm seeing a little bit of moderate bleeding here.
Okay.
Let me get this
That
placenta.
can happen. Look at your baby.
All right. There's the placenta. Placenta delivered. That pit's running?
Yep.
Excellent. Our bleeding's improving. Great job. All right, Nurse Jennifer, let's go ahead and initiate normal postpartum orders.
Okay.
QBL is about 400. Great job, ma'am.
All right, Miss Williams, how are you feeling? You look kind of pale. Let me see your vital signs here. 102/56. Your pulse is 126, and your O2 sats are 93%. Okay, well, let me go ahead and call my charge nurse 1 second, and let me check your bleeding. Okay, let me call her. Just 1 second. Hey, Tanya? Yes. Hey, this is Jennifer. I'm in 1235. Miss Williams here. She's bleeding a little more than I'd like. She's also a little tachycardic. Her vital signs are tend to be kind of unstable here. Our total QBL is 1,000, which is a stage 1 hemorrhage. Could you call Dr. Galati and ask him to please come to the bedside immediately? Also, please call Dr. Jackson, the OB hospitalist. Yes, thank you.
Hey, this is Tanya, charge nurse, and I'm just giving you a call about Miss Williams in 1235. She's got some increased bleeding with some change in her vital signs about 45 minutes after her delivery. Can you please come to the bedside? I'm initiating stage 1 of our hemorrhage protocol based on her vital signs, and she's got increased bleeding during her recovery. I'm going to go ahead and call the purple nurse also for some help. Hi, this is Tanya. I'm in room 1235, and we need an extra pair of hands for a postpartum hemorrhage. Can you please bring the hemorrhage cart and grab the medication kit out of the Pyxis? Thanks. Bye.
Ms. Williams, we're in the process of stabilizing your anticipated bleeding. You are doing great. Just keep on telling me what's going on and what you're feeling. All right? We'll have the doctor here momentarily. Oh, let me check this baby. Where's Dr. Jackson? Hey there! Hey!
Can you tell me about what's going on?
Yes, so this is Miss Williams, this patient you saw through triage. She's high chronic hypertensive. She delivered about 45 minutes ago. We've had a total blood loss now so far, another 600 from delivery, which was a total of 1,000 QVL. Her vital signs currently are, let me take a look here. She's got a blood pressure of 100/60 with a pulse in the 130s. She's currently on magnesium sulfate, and she's had a history of a postpartum hemorrhage in the past.
Okay, can we go ahead and get the hemorrhage cart, please? Hey, Miss Williams, I hear you're bleeding a little bit more. How are you feeling? Okay, so I'm going to go ahead and examine you. All right, let's see what's going on. Okay. So,
Just hold on.
all right, Miss Williams, it looks like you have something called uterine atony. It's just where your uterus isn't contracting down as much as we would like. And we're seeing some blood clots here, so we're going to work on it, okay? Jennifer, what have you done so far?
So far, I've bolus oxytocin, I've done fundal massage, and that's pretty much so far what we've done.
Okay. Have you given Methergin?
Yes, we gave Methergin. But nope, we can't, because she has preeclampsia. Looks like she's had another loss of 350 QBL. Now it's 1350 since delivery.
Okay, let's go ahead and place a Foley. Go ahead and send that type and cross for 2 units and send our set of labs. So that'll be CBC, CMP, PT, PTT, fibrinogen.
Sounds good.
And let's go ahead and give Cytotec 1000 PR.
Let me grab Tanya. We're gonna need meds. And then the hemorrhage chart.
Hey Jennifer, I brought the hemorrhage cart.
Awesome.
You want to go ahead and start an IV and draw labs, and I'll go ahead and give her medications.
Perfect.
Okay, and if someone can record, Amy, can you record on our postpartum hemorrhage worksheet here?
Mr. Lottie on the phone.
What's going on? Everyone's catching up on what's been happening. Someone? Here's Jennifer.
Jennifer,
From delivery, we've had a total blood loss of 1350.
Okay.
She's her vital signs have actually been a little unstable. Currently, her blood pressure is 90/49.
Okay.
Pulse is in the 130. I'm going ahead and starting an IV. We put in a Foley, and we are got the hemorrhage cart. Tanya called. Anesthesia's aware. The whole team is assembled.
Okay.
you have labs sent. You've gotten 1,000 of Cytotec in addition to the Concerta.
And you said the OR is ready?
OR is ready.
Okay, thanks so much. Well, we're obviously in the second stage of the hemorrhage protocol because of her vital sign instability and her continued bleeding. So let's go ahead and get some Hemabate ready.
Actually, hold the line. We can't give Hemabate. She actually has a history of asthma as well.
Okay, thanks, great catch. Let's go ahead and get some TXA loaded up, and I'm going to perform some bimanual massage here. Okay. Yep, still atonic. Let's go ahead and get transfusion of 2 units of packed red blood cells started, please.
Hi, I'm the anesthesiologist, and I brought the rapid infuser in the blood products.
Welcome.
Awesome. Here we go.
Belmont Rapid Infuser. The Belmont Rapid Infuser is located near our 3 ORs. It should have hanging on top of it this patient belonging bag containing the actual tubing for the Belmont infuser. You have this tubing right here, which is an extension that you need in order to hook up to the IV line. The next tubing is this right here. And this is the one you're actually going to thread into the Belmont Rapid Infuser. This does not come preset with fluid. You do need to get your own normal saline. It does not hang with any lactated ringers. Let me make sure it's all there. Go ahead and attach your tubing, light blue to dark blue. And we can go ahead and hang it up. going to put the chamber in this little lock there. Make sure both or all of them are locked. All right, let me measure this. Oh, okay. So, Dr. Delotti, we're now at 1600 QBL,
Okay.
which puts us at a stage 3 hemorrhage
Okay, I agree. I think we should place the Bakri balloon now.
of Bakri's.
Yes.
All right, here we go.
We have a syringe and a saline.
Yep. Saline. And the 60s.
Spike a 500 milliliter IV bag with the provided bag spike and connecting tube. Flush the connecting tube with saline to expel any remaining air. Attach the red fitting on the IV tubing to the port that is labeled with a red band on the three-way valve. Attach the three-way valve to the inflation port of the Bakri balloon. Attach the syringe to the remaining port on the three-way valve. Now you can begin to inflate the balloon. Pull back on the syringe to fill it with saline directly from the IV bag. Press the plunger forward to push saline from the syringe into the Bakri balloon. If desired, you can apply traction to the balloon shaft. After you inflate the balloon to the desired volume, Close the stopcock on the Bakri balloon and remove the rapid installation components. Remember, the maximum indwell time for the balloon is 24 hours. The balloon may be removed sooner if the clinician determines that hemostasis has been achieved.
Okay, labs are back. Her hemoglobin is 7.1. Vital signs are stable. That sounds good.
Great. So, Ms. Williams, it looks like your bleeding has stopped, your vitals are stable, your labs are normal. You're going to live. Yep. All right, team, let's go. Roll out.
Okay, so we're gonna go ahead and debrief everyone. So
what went well?
I think everyone got to the bedside pretty fast. I also appreciated that Tanya assigned roles and tasks during the hemorrhage in the room.
So we communicated well?
Yeah.
And I think you did a great job, Jennifer, keeping us up to date on the hemorrhage stages that we were on. And also, you used cuss words to voice your concerns and advocate for your patient.
Good.
Great job.
Thank you.
So what do you think we can make improvements on next time?
I noticed that we didn't call back orders for meds. Next time we need to call back the orders to the doctor so we can avoid any med errors. I think that would be important, right?
I agree, yeah. Next time we just need to call back and repeat orders so to avoid any med errors. I think we also made some good catches.
All right. Well, if anyone has anything else they'd like to talk about?
I think that concludes it. Jennifer, just don't forget to fill out your variance report and your code purple.
Yep, and our code purple sheet will turn in.
Awesome. And it's great that we recorded everything on the worksheet.
Okay, so that drill was on our stage-based hemorrhage protocols, which is something that we are working on with our quality committee. You can find information on that on the hemorrhage cart. These stages are based off of the CMQCC, or the California Maternal Quality Care Collaborative, and have been validated by Texas A&M and are being rolled out to all the hospitals. So every hospital in Texas is implementing this. It's not just us. It's evidence-based, has been shown to reduce maternal morbidity and mortality, reduce the need for, ICU stays, etc., with early active management of blood loss. So when you go in and you have your hemorrhage of 1,000 mLs, you have your stage 1, okay? So you've met criteria for a postpartum hemorrhage or increasing bleeding during recovery. Then you look at your little chart here, and your nurses will be doing this for you, since we'll be actually managing the hemorrhage, but someone in the room should be following this. This is why we do the QBL also, and it kind of tells you what you need to do, right? So stage 1, we're at 1,000 mLs, we've hit hemorrhage, you're monitoring vital signs, you're checking your QBL, we're making sure the bladder is empty, all the things that we would initially do during the hemorrhage. We hit stage 2 once we're between 1,000 and 1,500 with continued bleeding or unstable vital signs, and this lets you know how to escalate and what we should be doing, right? We're getting our second IV, we're sending off all of our labs at this point, we're getting our blood to the bedside, we're transfusing with the continued bleeding, we have our blood warmer, and then just other things to, remind the staff to keep the patient warm. We're activating our OR team and letting them know that, hey guys, we have a more serious hemorrhage at this point. If your cumulative blood loss reaches greater than 1,500 mLs, you've given your blood, there's signs of DIC, vital signs are unstable, she's oliguric, you've hit stage 3. And at this point, you should be getting your second anesthesiologist, your second surgeon, the OR team should be there, you should be calling for the massive transfusion protocol, and these are the other things that, we should be doing. You repeat labs every 30 minutes at this point. And your nurses should be, vocalizing where we're at on the stages of hemorrhage, and then the protocol is that we're responding accordingly. Once bleeding has stopped, we can kind of manage it from that point. But with ongoing bleeding, ongoing hemorrhaging, this is the escalation process.